Yeah, my name is Richard Hirth. I'm on the Faculty of Health Management and Policy here at the university, and I have the privilege of chairing this group of employers and insurers and looking at their perspectives on the ACA. So if we look at the headline in the Detroit Free Press today, it was that Michigan has a 5.9% unemployment rate, which is the lowest rate it's been since 2001 in the early months of the Bush administration. And we also see that nationally about 43% of those eligible for the health exchanges have enrolled, and in Michigan that number is more like 50%. And we see that this growth in jobs we've seen has been pretty broad-based. Almost all sectors of the economy have had growing jobs in the state of Michigan. So at least on this very macro sort of 30,000-foot view, the most dire predictions about the consequences of the ACA likely have not come true. However, kind of like a car, you might be driving home and your car is fine, but you don't know that there's a fraying belt. So what we're going to do today in this panel is look a little bit under the hood of the car and see if there are any fraying belts we ought to be concerned about, even in this sort of overall 30,000-foot view of things looking pretty good. So if we look at the different provisions of the ACA that potentially affect employers and insurers, there's obviously a myriad of them, given the complicated nature of the act. There are mandates, both on the employer side and the individual side. The employer side, they start eventually with 50 employees or more, 50 full-time employees or more. And again, both on the employee and individual side, as we know, there are penalties that are going to be imposed for those who fail to meet the mandate. There's the shop marketplace, which is intended to help small firms get coverage. It's essentially the analog to the individual health exchange, but for small groups. There are out-of-pocket maximums that have been imposed. Limits on lifetime benefits can no longer be imposed. There is a series of essential health benefits that all plans must cover in order to be qualified coverage under the ACA for meeting your mandate. There are rating rules, age banding, restrictions on what you can and can't rate for. There are things looming like the Cadillac tax in a state like Michigan that still has a fair union presence relative to much of the country. That certainly is an issue between labor and management going forward in terms of the generosity of benefits that are negotiated. So there's obviously a ton of moving parts here, some of which have been delayed to a certain extent, such as a shop exchange going online, some of which haven't taken place yet by design, the Cadillac tax. So we have a group here that has essentially two employers representing their own perspectives of their firms. We've got two individuals who are representing sort of broader sets of employers and the experience of broader sets of employers, and we've got one lone representative of the insurance industry. You might want to sit at the end so you can make an easier escape. I'll let you decide if you want to switch seats. Join me in welcoming the panelists. We have Roy Lamphere, the Vice President of Insurance and Affinity Programs for the Detroit Regional Chamber of Commerce, obviously representing firms of many different sizes, many different industries, many different characteristics that are members of the Chamber. We've got Kirk Roy, Vice President of the Office of National Health Reform for Blue Cross Blue Shield of Michigan, our insurer representative. We've got Madeline Smith, the Operations Manager of the Michigan League of Conservation Voters, who, if I read correctly, have about 20 employees now that you're trying to figure out how to get the best coverage for. We have Craig Start, the President of the Michigan Dental Insurance and Financial Group. Kind of an interesting perspective is he'll bring sort of two different perspectives, both as an employer, what was done in their organization for their 50-some employees, and the perspective of somebody whose organization helps provide coverage and link up plans for dental practices and firms in various other industries that they do business with. A lot of legal practices, a lot of small employers, small retailers. So it's not just dentistry that they're involved with. And then finally, last but not least, we have Lori Weigler, who is the Chief Financial Officer of Orleans International, a firm that has about 40 employees. So that's one of the things to kind of preview a question that I'm going to give to Lori and to Craig, is one of you is just above that 50 mandate, that magical threshold. The other of you is just below that 50 threshold. So kind of think about how you might want to communicate to the audience about your thinking with regard to that magic number of 50. And is it as onerous a number as it seems? Is it really affecting your growth strategies going forward? So I'll give you a little preview of a question there. But right now we'll kind of start, go from left to right as I'm facing, you're right to left, and each speaker will have about 5 to 7 minutes to kind of give us their perspective on the implementation of the Act so far, how it's affected them. Okay.
So I suppose that means I'm up first, huh? Terrific. Can you all hear me terrific? Are you pretty excited? Healthcare, ACA? Good. I'm excited, especially since I'm sharing the stage with another Roy. I don't get that every day, but terrific. Also, I have a confession to make. While I do work for the Chamber and represent lots and lots of employers, especially in the healthcare space, in a previous life, I did spend time as a head of pricing and underwriting. So I was the person who was building and pricing those evil products that you all have to use. And when I had enough fun doing that, I went to the provider side, where I was essentially business development, figuring out how to make money for the system. So yes, as a form of atonement, I went to the Chamber to consume all those things. So today, what we're talking about a lot is the impact of ACA and as it relates to employers specifically. I can tell you kind of fondly, I remember when I joined the Chamber, this is long, let's just say over a decade ago. So I remember presenting in front of a room similar to this of small employers really jazzed up about cost, and we need to do something, we need to drive discounts, we need to do something. And I had this really great idea, and I'd just be honest with them. And I said, you know what? Costs would be lower if you were healthier. And they all were like, get out of here. You know, this is not what anybody wanted to hear. But, and I was joking, but you know, the reality was health was an issue and costs were an issue. And that was over a decade ago. And you know what? Cost is an issue, health is an issue today. And those two are not independent of each other. So I sometimes cynically refer to health insurance as sickness financing, just to make my point. We're not really paying for people to be better. I mean, it's not if I'm an employer with my CFO hat, I'm not thinking, oh, I'm going to buy an inpatient day and all of a sudden I'm going to get healthier employees. You'd like that to happen, but it doesn't. But I'll tell you but even before ACA was enacted, we saw two trends happening in the small business space, primarily because of cost, which was, one, small employers were increasingly shifting cost in terms of higher copays and deductibles, so pushing more of the expense to the individuals as a way of coping with costs, or they were going completely the route of individual coverage, right? It wasn't as quick as it is today, but that was what was happening. And I think when you look at the trends now, there's one other aspect that we saw, and I think anybody who's been involved with this can attest. Cost impacts everything, right? It takes away from our disposable income. It impacts state budgets. It impacts the federal government, the Army, for instance. I mean, with the retirees. Cost impacts everything. And I don't want to make this about, you know, it's just the dollars. But cost and health, I mean, you have to solve these things together because that's the big pressure. So when I look today, when people were talking about ACA, and I remember even talking about this with the Blues, who are a great strategic partner of ours. One of the things was there was no impression that this was going to change cost. Cost was still going to be an issue. That was one thing that I can guarantee. If no other reason is because you're all going to get a year older tomorrow, and just probably not get a lot healthier. So maybe you're healthy, but everybody else. So that was one issue. So you knew that you're always going to have that pressure. The second thing was that there was going to be this continued fragmentation and individualization of care. And what I mean by that? Well, one of you smart students can come up with a better term for this later, but what I'm driving at is that as costs increase and we start to shift costs to our individuals, it becomes more of an individual burden. The onus is more on me. Whether it's I go the route of having a savings vehicle and a high deductible plan, right? 2 products. Now I have to figure out, I'm now a consumer because I'm paying for it. Seems generous as a term. But, or if I'm having to go through products such as more managed care, jump through more hoops, now there's a lot more onus on me. And now you're seeing the prevalence of narrow networks. So now as a consumer, I have to figure out, I can go to this doctor, whatever. It's more on me as an individual to figure out what happens. And then the third kind of trend that was going to happen, and I think you see it today, is just the administrative burden. And I use that to generically describe whether it's trying to meet compliance needs, right? How you enjoying that next bit of reporting? Or, hey, Kirk's in this boat too, so the Blues had to go through a lot of that. Or just the communication burdens, right? As insurance products become more complex, or there's more things that I have to require of an individual, I have to communicate more, right? And then as individuals, you too have more burdens. Do we not all have a mandate now, right? And now I also have to go navigate new things as I become more responsible. So those are kind of the big trends overall that I see. And then I think I'll save kind of the future stuff. I see where healthcare is going, and I'll just say there's going to be some unintended consequences as you get to, maybe it's not unintended, but as individuals become more responsible for care, you're going to see just a general fragmenting of the traditional systems. The Blues are going to have to operate, every carrier is going to have to operate differently than they did before. Same with hospital systems. You're just going to see a lot more individualization, largely because of technology. So, 1 minute.
Long time.
So my name is Madeline Smith. I'm the operations manager at the Michigan League of Conservation Voters. I've been there for about 3 years. And when I started, we had 10 employees. A couple of them were full-time. Now we're up to 21 full-time employees. So even since the ACA has been implemented, our organization has changed a ton. But when I took this role mid-2013, we had a small group health insurance plan, and we also offered a stipend to our employees so they could choose one or the other. And just with turnover and everything else, we got to the point where we had one person left on that group plan. It wasn't a super comprehensive plan. It was complicated, and so a lot of people just opted for the stipend. We also have a pretty young staff who were getting coverage with their parents. We had a couple people who preferred the coverage that they had with their spouse, and so we're not interested in that group plan either. So with the impending implementation of the ACA, we thought, well, this is a really good time to reevaluate what we're doing. Maybe we don't even want to have this group plan anymore. So we did some research. We looked at what we could afford to provide to our employees, also kind of surveyed our salary levels and maybe what subsidies our employees would be eligible for, and decided that it would probably be better to just get rid of that group plan altogether. So we gave that a try, and all through last year and continuing now, all of our employees receive an additional, like a salary addition basically, to their paycheck each month. We can't call it a stipend, it's a taxable benefit that they receive. But we have 2 different salary adjustment levels, I guess you'd say. If our employee is shopping on their own, if they're not on a spouse's or a parent's plan, they get 1 level of the stipend. But if they are on a spouse's or a parent's plan, there's a different, and it's called a stipend. Not a stipend, don't say that. They get a different salary adjustment each month. So it's a taxable benefit, but it's there and they can use that however they choose. When we got started with just doing the salary adjustment, we had a couple people come in and talk to our employees about using the marketplace. That's definitely one option. They could also go to a private insurer, whatever they preferred. But we worked with the Detroit Regional Chamber. We had someone come in from the Washtenaw Health Plan just to make sure that this wasn't like a super daunting process for them. So it's pretty simple and straightforward, but that's kind of what we decided was best. And then in September of last year, we surveyed our staff to see how that was working for them. And really just wanted to make sure that, everyone was getting covered. There wasn't any glaring issues with this. And we were kind of surprised to see that most people were really happy with it. I thought it was going to be a little bit more polarizing, but a lot of people were really happy. There was a few people that said if we did offer group coverage, they wouldn't be interested in moving to that right now. just because of the subsidies they're able to get for their family right now. That being said, and as I mentioned before, we're in a very different place now than when we started with this. We have 21 full-time employees. We're a much more sustainable organization. We're a lot stronger. And so we're really looking forward to doing another survey this year to see if this is still the best way to go. I think whereas before we were maybe just looking at just straight health insurance, we might be able to offer more types of coverage as well. So this could be a kind of a redefining year for us, but thus far, I would say overall we found the salary adjustment it really met the needs of our employees and our internal staff capacity to offer coverage. So yeah, I'm excited to kind of hear what other groups are doing. We don't plan to be any bigger than 50 ever. We're excited to find ourselves at 21, but you know, getting close to that number, how can we provide better care for our staff and be a more sustainable organization?
Okay. Well, Lori Weigler, and I am the CFO and the Human Resource Manager for my company. We have about 40 employees. It was interesting being in the role both of a CFO and a Human Resource Manager. I thought that was a unique position. And with the ACA coming on and all the changes, I actually thought it was probably a great position for me to be in because it forced me to research not only the best financial options available, but the options that would continue with my employee satisfaction. We didn't want the costs of one to offset the other. That was a huge concern for me, and it was a huge concern for our employees. So I thought it was interesting at the beginning, though, when Richard said, you know, we've got someone who's just over the 50 threshold and another employer who's just under the 50 threshold. That 50 number under this new ACA is very different. What that means is now, if you're under 50 employees, you are now under an age-rated plan. That is very, very difficult. Under the age-rated plans, 50 is now the new old. So if you're about to be 50 or are 50, congratulations, you're now officially old. And expensive, very, very, very expensive to insure. When we met with our insurance broker to go over what our increases were going to be with our policies to keep, as they kept saying, the same plan. You can keep it, okay, but at what cost? As an example, one of our main employees was 50, her husband was 53, she had an 18-year-old daughter and a 19-year-old son. Her insurance under our old plan, high deductible plan, was no longer going to be allowed because the high deductible plans were no longer being sustained under the plan. Her insurance went from $600 a month, which we covered all but 20%, to $1,600 a month. So for an employee who, like this, is what I consider the working class poor, she's in the middle. You know, she and her husband both have nice jobs, but they have 2 teenage kids in college. The extra, just at the 20% copay, was $200 more a month just for her. For some people, this is a car payment. This is not in any way affordable. So when I looked at our employment group, I looked at them as a whole, and I said, okay, what options do I have? We had a management group that were on a PPO plan, and we had our support staff that, for the most part, were on an HMO plan. They could buy up to the PPO plan if they wanted. Our HMO plan, which are the people who, again, the support staff, could least afford to take on that extra expense, and the extra expense was huge. For our PPO class, we already had a robust policy, so the extra expense wasn't that prohibitive. And quite frankly, those employees could afford an extra $100 to $200 a month for their same health care without changing their standard of living. So after talking with a lot of people and looking at our group as a whole, we said, okay, could we, rate everything together and average it all and just charge an employee X percent? Well, unfortunately, that was going to hurt 15 of my employees and not really help a lot. Then when I looked at, okay, if each person has to take on their own insurance responsibility for the increase, what would that be? That was going to hurt a few of my employees, but it was going to make it completely non-negotiable for those employees, unaffordable in every sense of the word. So I had discussions with people in Lansing, as well as a lot of different people even at the chamber I spoke with. I also spoke at another meeting, talked with a lot of people to get their advice. The most helpful came when I talked with someone in Lansing on Medicare and Medicaid and what was being done. So I looked at the plan and I completely revamped it. And I said, okay, what we're going to do is we're going to change our plan to fit our employment group. We said all employees over 65 are no longer eligible for coverage under our plan. So that put all of our people onto Medicare, which included 2 of the 4 owners, who, needless to say, were not thrilled with that decision, but we felt that they needed to do this as well. They couldn't be grandfathered into something else. They needed to show the employees their support for this. So our employers, if you were over 65, all of our employees went on to Medicare. We brought in an insurance consultant during the workday to enroll them all, to give them their options for buying up their prescription coverage, for what they could do for covering themselves in the black hole situation, so they had to buy extra coverage. And then we went ahead and said, okay, we know how much all of your Medicare coverage is going to cost because you didn't pay it before. We put the stipend, so to speak, in their salary, and we grossed it up so that after tax, they did not have a cost for that. Then what we did is for the rest of our group, we said we will cover you and 1 other, whether that be a child or a spouse. So if you had 5 children, you were still only covered for you and 1. If it was just you and a spouse, it was you and a spouse. So then we had to figure out, and we had a small percentage of those employees, what do we do for those extra kids? Because again, this was a problem that was forced by employees that couldn't pay for that differential. We got help with signing up those teenagers on Medicaid. Now, the employees were not happy about the stigma of signing up their children on Medicaid, but I convinced them that this was the right thing to do. The other option was they could pay the cost of adding them to our policy, which was for each of those children about $300 per kid. That was the minimum. That's not affordable. Well, they did that. They were very successful getting their children on the Medicaid, and that has so far worked out quite well. We looked at the option, much like Madeline said, and I think we talked at one of the other meetings. We looked at that option of, okay, maybe we do away with insurance. We may be a small employer group, but we're a $700 million company. We need to attract talent. We couldn't afford to not offer insurance benefits, so we modified them to fit our needs. But when we looked at what could we do for these employees if we did a stipend, we actually went out onto the marketplace to see what could we get for those employees on the marketplace. We found that none of our employees qualified for the subsidized benefits. And so if we gave them the stipend and they went out and purchased it on their own, they weren't going to get a savings. It was still going to be costly, plus it was no longer pre-tax dollars being used. It was after-tax dollars. So that was a problem. And much like was said earlier, I believe Chris said, the average cost was $336, and that's if you can get subsidies. So for our employment group, it was still $800 or $900 a month. $800 or $900 a month is no more affordable to them than $200 a month is affordable to the person who is indigent out on the street. They're just not going to buy the services, and we found that our younger employees, if we gave them the stipend, had said they'd take their chances, they'd take a raise, they were young, they were healthy. What the heck, why not? And the most important thing that I keep thinking, I heard Marjorie talking about today that really weighed heavily on us, is just because you have an insurance card doesn't mean you have access or availability. The access being a problem and the affordability, it just simply wasn't. Now, if you have a group that's over 50, you didn't have as much of a dramatic effect of that. But for our group, it was huge. So we really need to talk to a lot of people. I spent weeks doing research and talking to people to find out what our best option was. So you can customize that and use consultants to help you find what's right for your employment group, because everybody's different. So I think the only thing I was going to say is in closing is, I heard some other people say, we've just gotten started, or we have a long way to go. But you know, I really feel like success, when they talk about success, you hear in the papers, success, it's been a success. All of these people have signed up. That's great. We've got a lot of people signed up, but if they don't have access, it doesn't mean anything. And if they can't afford it next year, they could afford it this year, it still isn't success to me. To me, success is going to be measuring the outcomes and the happiness, the success of the people using the product. To say it's successful that people signed up for it would be like in my business, us defining success based on the number of sales versus the profitability. It doesn't make sense. So I loved Marjorie's suggestion of we need everybody to get in a room and figure this out, because it's not working for a very large percentage of the working class population.
All right. Well, based on that, I'll tell you a little bit of my experience. Again, Kirk Roy from Blue Cross Blue Shield with the Affordable Care Act. I actually got a phone call the day after the bill was signed into law in 2010, and they said, you have a new job, healthcare reform, Affordable Care Act, make sure everything goes right, make sure nothing goes wrong. Good luck with that. So that was my entry point to there. And you know, as an insurer, we spent scores of millions of dollars just bringing all of our systems, infrastructure, all this to alignment to meet all of the mandates. There's more than 100 distinct mandates that have already been implemented and still dozens more. So, you know, the fact that my role even exists at an insurance company means that there's a lot of work, and it has been a big impact on what we've done as a business. You know, we ensure that more than 4 million people in the state of Michigan have coverage, and including employers outside of Michigan's 5 million people. We've changed every single one of those people's policies at least 3 times, some of them 6 times, depending on that. So that is the actual legal policy filing that has to go to the state. That is the actual computer system. It's the customer service line. It's all of that sort of thing, the website. So it is a tremendous lift to make the infrastructure of how insurance works work with the Affordable Care Act. So great, grab me a river, right? What it actually means, though, for us to be able to do that is we play an important role in making sure the financing works. And sometimes I do say that the Affordable Care Act did go a long way to actually getting people at least have a starting point for coverage. We're certainly not done. But a lot of it, from my perspective, of course, you're standing in my shoes, a lot of it was not necessarily health care reform. Some parts of it were more health insurance reform or health care financing reform. There was a lot of that. So we do have a long way to go, but when I do look at the things that have been successful, I was worried about 4 major things as a company who plays an important role in insurance and financing of that sort of thing, but really the why we do it and the role that we play in the broader sort of healthcare ecosystem here in Michigan. We wanted to make sure that where people got their coverage was working, right? And so we made a commitment to, whether you liked it or hate it, we were trying to make it work. But I was worried that the employer market and the employer coverage would evaporate, or that it would get decimated. Okay, that hasn't happened, so that's good news. I was worried that we collectively, at the state level, at the federal level, at our own company's level, wouldn't be able to figure out this Medicaid expansion. You've seen the Healthy Michigan program that so far has been successful. Again, you heard the work to do there. I was worried that the individual insurance market with the health insurance would blow up. Now, there were technical issues in the beginning. It didn't blow up. There are people enrolled. I was more concerned with, with the same background as Roy, from the numbers part. Would that be a sustainable financial mechanism in terms of people coming in using coverage and then going home and not sort of being in the insurance pool? And that hasn't happened yet. We're finding that that is at least stable, not affordable in all cases, but stable in terms of it's not blowing up. And the last thing I was worried about was the Medicare program. Now, the Medicare program still has issues, but in terms of their changes to the Medicare Advantage program, would we collectively be able to continue that to be able to serve people on Medicare? And so far, that has been going on, but it's been a massive transformation in how the funding and delivery of those programs work. So I always was in the position, even in my own company, let alone coming to talk to all of you of that sort of thing, around being the messenger. right? So I'd even go around and internally in the company and say, well, this is what it means, and this is what we're going to have to change. And people would be like, what? We're going to have to do that? We're going to have to change that? But don't you realize that's going to mean this is going to happen to people's benefits, and this is going to happen to people's rates, and if people are already confused, aren't they going to be more confused? And the answer to all of those things has been yes. And so that has been the biggest challenge. It was my full-time job to think about this, and I was having a hard time keeping up, so let alone, right? This is not what you're doing every day. It's not what anybody's doing every day. How do you make sure we do that? And that has been a real challenge. So while we've seen, my deepest worries not come to pass, you've seen some successes, it has been really challenging to get from here to there. And it really comes down to understanding how does that whole subsidy thing work in the individual market? How does the whole pay or play penalty work for employers and for individuals? Then the biggest things that I think were surprises to people, you heard, hey, there'll be standard coverage and there'll be standard rates and everyone will be guaranteed issue and anyone who wants a plan can have one. But from that set of rules, from where we are today, the abrupt change in terms of what meant for what's covered and how rates are set is where you're hearing all of the stories around, on average, nothing changed. But no person, individual, or business is an average, right? And I think you're going to tell some stories around one particular circumstances, you could have the costs double. In another circumstance, you could see an employer and their costs were cut by 25%, and it was all over the map. And how do you explain that and what was driving that? And a lot had to do with what the coverage levels were, the benefits, and this thing around, especially businesses, were rated not on the average, every family household was set one particular rate. It was, well, what is the family composition of your household? Age, dependent status, all of that stuff. So we were required to now rate and send you all premium bills that looked like that. And that's a very abrupt change in addition to all of the other pieces of the rule. Or rules involved there. So the important part about all of that is it has been disruptive. And in fact, there are additional changes, right? The new magic number might not be 50 employees, it might be 100 employees, depending on what happens over the next, they just introduced legislation to potentially not have that happen. But bottom line, there's more of that transition to come. And I actually see this also as sort of the beginning of the conversation, getting through this transition we have right now. All of our collective reaction to really understanding what it's mean and revisiting it from employers, healthcare providers, governments, insurers is actually going to determine the long-term success, and it could easily get into a spot where we're all reacting to the real reality of what's happening right now by trying to, as much as possible, retrench to our own positions or the older system that we wished we had, as opposed to getting in the room. I also like can we lock ourselves in a room and figure out how we're going to do this together, because that will be the ultimate long-term solution with this. With that, I'll turn it over to you.
Thank you, Kurt. My name is Craig Starr, and I am president of a company called MDA Insurance. We're a subsidiary of the Michigan Dental Association, but we're an insurance agency. And when we started 30 years ago, our focus was on dentistry, but over time we've evolved where we actually are the agent for law firms, for retailers, for folks in the Michigan green industry, which are nursery and landscapers. So a pretty wide breadth of businesses that we work with, anywhere from professionals to people who are out getting their hands dirty. And predominantly these businesses are real small businesses, 10 or less, probably less than 5% are 20 or more businesses that we work with. And as such, being under that magic number of 50, none of them have ever been required to offer health insurance to their employees, and they're still not required to, even under the Affordable Care Act. But even though they're not required to, they all have. That's why they're my customers, because they're offering health insurance to their employees. They all do that for various reasons, whether it's to recruit and retain good employees, or to keep their employees happy, or just to be perceived as a good employer. They've done that. And unfortunately, they've had some really hard decisions they've had to make over the last few years. Blue Cross uses the word disruption. We've heard a couple of the employers, one that decided just to stop offering coverage altogether, and send their folks out on their own. Another one who had to do some serious revamping and remodeling. Well, that's what we've had to do with over 1,000 employers in these industry, and predominantly a lot of it was done last fall. From last October through the first of the year, my staff was working 12-hour days. We were working the day after Thanksgiving, Christmas Eve, all that stuff because of all these deadlines. Basically, every one of those people, that concept, if you like your insurance, you can keep it, was not true for them. They all lost their coverage. It's 1,000 businesses, it's 5,000 contracts, over 12,000 people when you add up the spouses and the kids. They all lost their coverage over the last 18 months, and we had to get them all from point A to point B to a new program. Predominantly, those people didn't lose their coverage. You hear a lot in the media, well, those were inferior policies or not good policies. No, they were Blue Cross policies and they had good coverage. But one of the codicils of the Affordable Care Act forced carriers like Blue Cross and all the carriers to lump all their customers and businesses under 50 into one risk pool, and that necessitated all these policies to end. As Kurt said, some of them had to change policies 2 or 3 times over the last few years. Well, as part of that process of changing, there was winners and losers, essentially. And in the case of the winners, or maybe not even the winners, people who benefit might be a better way of saying it. We spent a lot of time talking at the first panel about the Medicaid expansion, and I'm a big fan of that, from what the state has to put in dollars to versus what the state's getting in return. Those folks have definitely been helped, and that's probably our neediest citizens in Michigan. Another group that definitely benefited was some of the lower paid employees that we work with. Oftentimes they're part-time employees. Maybe they're a single mother with responsible for several kids, and they're eligible for that subsidy, and they can get that plan subsidized and pay a lower premium than they would have had on their own. But unfortunately, those people who are benefiting in my world are probably about 15 or 20%. The other 75, 80% of the folks are looking at higher premiums, higher deductibles, higher copays. The decision makers in those businesses have had to make hard decisions on, much like Lori described, of my person's premiums going from $600 to $1,600. What can I do about it to not make them be $2,000 or $3,000 out of their own pocket? And so a lot of tough decisions that they've had to make. Within those small groups, the under 50 groups, again, probably 4 out of 5 of those businesses were looking at higher premiums. In particular, if you happen to have those older employees, because of what Kurt was talking about, age rating. In the old world, if you had a business with 10 employees, every employee had the same premium. It was a blended rate based on the average age in your office. And now each employee gets their own rate based on their age, and that person's spouse gets a different rate based on their age, and that person's children all get a rate based on their age. In the old days, kids were what I used to call cheaper by the dozen. It was one price for 1 kid or 10 kids. It was the same price. Now each kid has a price tag on it. So your bigger families are also seeing those bigger rate increases. And those are the folks, again, that are trying to make ends meet on maybe a moderate wage. So we've seen a lot of pain in that regard. No matter your demographic or not, too, we do see, because employers have to make tough decisions. We've seen employers drop coverage. We've lost some of our customers because they drop coverage. We try to help their employees find individual insurance then if we can. And we've seen people that have to drop hours or play with the hours people are working, whether they're going to be eligible for that health care contribution or not. And that's unfortunate when someone's trying to make a living and can't get the amount of hours that they might want to work. So with that said, we've seen a ton of disruption. It's been tough on these small businesses because they kind of got swept in with the good of the subsidies and the Medicaid expansion. Somehow it was deemed that we needed to pull in all these small businesses into the pool, and there's been a lot of disruption and pain for those folks. I'm extremely concerned, as Kurt hinted, about these 50 to 100 groups. So right now I could count on one hand the number of my customers that are in that range, but as was mentioned earlier, I'm actually in that range. Our business itself is between 50 and 100, and the plan is next year, all those businesses have to go into these this individual rating pool, the community rating, the metal tiers, the essential benefits, and we're going to see a whole nother range of disruption, which is a fancy word for rate increases and premium or coverage reductions. So I hope that legislation that you said was introduced yesterday will pass, because it's really an unfair dichotomy. 50 is the cutoff point for the employer mandate. If you're 50 or more, you have to provide insurance to your employees, but yet they're going to put those people, the 50 to 100, they have to provide insurance, but they're going to push them down into the small group pool for the way they're rated and the way that the plans are offered. That is a double standard that I don't really think is fair to those size employers. With that said, I appreciate the opportunity.
Okay, thank you. I think everybody stayed right on time. That's great. All right. I've got a couple of questions to start, and then we have some that have already been submitted from the audience. The first question I have is, I'm going to give you the opportunity to be a senator for a day. You can repeal and replace one aspect of the ACA. What would it be and why? Anybody who wants to take it on?
Well, I'll just reiterate what I just said. I would have liked I liked the Medicaid expansion. They could have even gone a little further with the percentage of poverty level on that, possibly the subsidies for the lower income folks. But why did they drag all these small businesses into that? They didn't have to destroy what was out there in the small business pool to make that happen. And you know, if I could have waved that wand and made it not happen, I would have liked to have done that a couple of years ago.
Okay.
And I would actually second that, although my first thought was, I only get one. But if I only have one, I would absolutely agree that what happened with the small businesses and the age rating, the age-banded rates, you know, in Michigan, I was a CPA, a partner in a firm before I took on this position. You know, I had 2 large clients that were over 50 for every 10 I had that were under. The state of Michigan, the area I live in, is built on small businesses. Granted, we're right in the middle of the automotive industry with Chrysler and large businesses and government, but you know what? The majority of the people out there are working for those small businesses with under 50 employees, and those are the people that can least afford the increases, and they're the ones who were the hardest hit. That would be the single thing, if I only had one to choose, that I would change.
Okay. Kurt, do you have anything from the insurer perspective you want to add?
I was thinking about, that's a good question. The thing that most immediately comes to mind is flexibility on the benefit and rating structures. The purpose of those benefit rules and the rating rules was to make sure that people weren't getting sold inadequate coverage, and that they, you know, one class of people or employers wasn't being unfairly discriminated against in terms of the rates that were set. That was the objective. However, we've gone to such a standardized set of it, you can't even provide flexibility to meet different employers' needs. I would also say that the way that they were structured was modeled on what was needed for individuals, the individual-based rating, that sort of thing, when it, in fact, unless you all tell me otherwise, there was a very strong functional market for small businesses that was allowing, the wool was not being pulled over anyone's eyes in small business because they had advisors to do that, whereas individuals did actually need more transparent support and protection, and we didn't necessarily need to transfer those sorts of things to businesses. So that's my take on that.
Okay.
I'll email you more answers as I think about it longer.
I'll say from the, because I'm with the Chamber of Commerce, I have my obligation to say no employer mandates. But I will say to your point about the benefit design, it's short-sighted. The future is not going to look like, oh, I got my bronze plan, my gold plan. It's going to be fragmented. You're going to buy things independent. What if I don't want my primary care through the stupid plan that I got from the exchange? What if I want to go to this guy and contract directly with him? What if I want to create an alternate financing for reference-based pricing or something like that? And there's none of these considerations when you think about, oh, your plan has to fit in this box and it has to come from that guy, right? No, healthcare is going to be, when it becomes individualized, it's going to become incredibly fragmented, and individuals are going to want the opportunity to pull that apart. When you put the onus on individuals and you incorporate technology and transparency, they're going to be pretty clever with how they finance it. So trying to think that government's going to figure out this way for them is not going to be the way. And you're going to have also enterprising providers who are going to come up with different ways of delivering care. And there may be people who want to pay more for certain aspects of care. And so because we're getting away from risk and more into like, oh, what is a kind of a whole encompassing thing, I don't think it makes sense. I do think the one kind of underlying best thing about ACA is, and I say this with also twinge because insurers hate it, is that everybody in the individual marketplace has, there's complete access in that sense. Maybe not complete affordability, but everybody plays by the same rule. It used to be just the Blues were underwriting, they're the insurer of last resort. And from an individual standpoint, that would never have been an option for you to create it. Well, maybe if we give you some money or do something and you can get your coverage somewhere else. I think that as individuals start to cope with these, employers to cope with these costs, they're going to look for that flexibility, and knowing that you have a individual marketplace that's at least accessible, not necessarily affordable, is going to be incredibly important.
Okay.
That was still just one thing.
That's great. All right, I have a question for Kirk. So we've heard all these stories about premiums rising. We've certainly seen hundreds of thousands of new people being mandated to buy your product. So you guys are making a mint, aren't you?
I wish. Was there a question in there?
Yeah. Well, if not, explain why.
A couple of things. One is, the cost of the insurance product is primarily the cost of the benefits that people actually get from healthcare providers. And it's only known after the year it's sold, right? That's part of the challenge with doing that. So we actually had lower underwriting results in 2014 than we did in 2013 for a couple of reasons. One is, there has been some money spent, like I said, scores of millions of dollars just to make all the stuff work. The second part is people are actually using services, which you heard from the first panel. That's a good thing. That's what we're supposed to be doing. But not in any sense is, we added 10 people to a fixed cost business. It's a very real cost business. You add a person and they use services. People are actually, who didn't have coverage, here are some of that pent-up demand, they're actually using those services. I was worried that they'd use hundreds of millions of dollars more services. That's not happening, but they're using sort of in accordance with what the pricing is. The second piece, or the third piece, I guess, if I'm counting, is that we actually can't make windfall profits because there's this thing called the medical loss ratio rule. In the fact, other carriers, say Blue Cross did this, they would underwrite and try and get individuals to be at a spot where they were only paying out 50 cents on the dollar, every premium they took in actual medical care. That's actually doesn't happen anymore, right? You have to spend at least 80 cents on the dollar. People say you should spend more. So there's even a cap on what is available for employers or insurers to, quote unquote, make money on. So I think it's those three pieces, right? People are coming in, they're using services, that's a good thing. So there's not like any windfall profit around that. It costs money to make all the stuff that we're doing work. And if we ever make more money than we should, we give it back to the either the business or the individual policyholders, actually by law. So.
Okay. I have a few questions from the audience. The first one is, initially people were concerned about the adverse selection death spiral. What has actually happened?
I guess I'll start with that one. I was really concerned about that, this idea of pent-up demand with people who have never had insurance before or had insurance for a long time be somehow more risky sort of from the actuarial perspective, or less healthy, less savvy consumers of healthcare. And we haven't found that to be the case. We found that mostly there has been certainly a subpopulation that was in desperate need of some services, and they are getting those. But on average, actually, all of the new entrants to the individual market are on average healthier than that they have been before. The challenge with the small business environment was you heard this sort of thing about you didn't say winners and losers. The people who are benefiting, the people who hadn't benefit. The people who were sort of the groups, I should say, that had the most significant increases tended to be the ones that were the most healthy on average in the pool. So they had the biggest impact. So they were most likely to make a significant change. Now we haven't seen, there hasn't been a domino effect where that's caused anything massive that we're really concerned about, but we did see some of the, and it skewed to the more healthy folks, probably like you probably have a bunch of healthy people running around there. That they're the ones who tended to opt out of coverage, but it hasn't been a big domino effect so far. So we're still concerned about it for the longevity, and will people stay in over the long run is the real long-term question, but we haven't seen anything that's truly upsetting to us at this point.
Okay. And we've heard several of the employers talk about the age banding in particular. So the question is, was underwriting a problem for small businesses with unhealthy employees before the ACA?
So there was no medical underwriting in the small group market prior to the ACA at all. There is underwriting in terms of participation rules and reimbursement rules and stuff like that, but there's never been any medical underwriting in small group. And I would kind of add to what Kurt said. He's the one qualified to answer that adverse selection thing, but even in the individual market in the old world, Blue Cross was required to take all comers, and so I'm sure that's one of the reasons why they didn't see a big uptick in that adverse selection. They were already getting that adverse selection, and they already had that priced in their old products because they had to take one, take all. So we were unique in Michigan in that regard. That one of the things that was going on in other states was people who were not healthy couldn't get insurance at all. That was not true in Michigan. All insurance was, with Blue Cross anyways, was no questions asked. You're in, no health questions.
But in the small business market, you could always get coverage. It's just the question is at what price.
Right.
Yes.
Correct.
Right.
Correct.
But that's underwriting, isn't it?
Yeah.
Some people did break underwriting in terms of a couple of things. Issuance, right? Will you offer the coverage or not? And that's, I think, the distinction you're making. And then rating on top of that. Together, those two things some people call underwriting. I think technically we were saying you could always get coverage. The second part is at what rate? And there was a set of differential rating factors in the small business environment pre-ACA. And there was both in the individual market. Both other carriers could deny even offering coverage.
Okay, and now we're going half electronic. We have a question from Twitter, which was still delivered to me on a handwritten note card. What can state advocates and policymakers do to help employers? Can we learn from other states in terms of expanding insurance and controlling costs? What would you want from the state?
Well, they are the biggest purchaser. So I think they can set the tone for how a lot of the contracting flows. I'll just say from that standpoint, that's not necessarily a legislator's job, but I think that the market's going to have to drive where we want it to go versus kind of trying to legislate a course or a solution.
Anybody else want to take that one on? Okay, so any legislative representatives in the audience, you guys are pretty much off the hook.
We have a lobbyist team you can talk to.
A lot of this seems to be so driven from the federal level that it's just hard to come up with a state answer, I feel like.
Okay, and this is a question for Kirk. You are increasingly offering narrow network plans with lower premiums. How are you, fortunately it's very dark back here and this is a light card. How are you ensuring that the provider lists are up to date and that patients can access the providers they need? And what I might add to it is the concern that has been raised in some other states about people going to the hospital that's in network and there's an assistant surgeon or somebody that's signed on to the case without their knowledge who's out of network and charges them $30,000 for their 2 hours in the OR. How
Okay,
does that happen, and
good-
how do you prevent that?
Good questions. So a couple of things. One is we have been working for a long time with our value partnerships with hospitals and physicians, healthcare professionals to ensure increasing quality and changing reimbursement to more model around that. So when we do that, certainly there are provider groups and health systems that fare better, and if we can help people get to that higher quality care that has been grown from that, that's part of what they're doing. Also, it's what the individuals, as Roy said, are looking to, they're looking to find is I want a more individualized plan that works for me, because if you're an individual and your doctor's in the network, guess what? That's a broad network. So it's part of that demand. Are there challenges with making sure that as those provider networks change and are updated, that we get the information in people's hands? It is a big challenge. And so we are trying to make sure that we have better real times. In fact, I just came from a meeting where we are trying to make sure that all of those structures fit in our provider information data sets. And to be honest, we are not as far along as I wish we were in being able to have that real time in front of people. And the last thing around is, what is the reimbursement model? Today, it's you're in the hospital, but depending on who you're working with in the hospital, it's a different billing structure. And so the evolution of, we've been trying to move very far towards away from fee-for-service to fee-for-value, and that value-based reimbursement, we are not all the way there yet either, to make sure that it's either clear and bundled and that sort of thing. We would love to be in a position to be able to say, if you're working in that hospital, you will accept our reimbursement in full and participate in this network. There's not agreement with the providers working with that is something that we can get to. But that is the type of thing that we're working towards. So we're trying to be as informative, but it is a challenge. So I think it's two fronts. How do you get the right information in people's hands, technology, real time, and that sort of thing, and how do you also work with the provider community to make that a more seamless experience through the contracting and reimbursement approach? So it's both of those levers.
Can I just add that I think that transparency and that narrow network are going to go hand in hand, because really what you're talking about is the narrow network is just a different type of reimbursement level or coverage level for the individual depending on where they go. And you're trying to just figure out, well, this guy, I get more covered versus this guy. And I think when you start to get to more, we're not used to using transparency as consumers, but I think as we start to go that route, you're going to find that it's not going to be just this network, that network. It's going to be, what is this cost, what does that cost, and what is my take on each of those things. And I think you're absolutely right about the system's ability to tell you work with you on what things are going to cost or what's going to be done. And there's going to be a lot more, I do think technology is going to do it, is going to be a lot more of, you're going to need more advocates for you if you're going to have all this onus on you about what you have to do, what you're responsible for. I can see a day where before the claim happens, you're having an advocate with you working through the system for clinical reasons and for reimbursement reasons.
Yeah, if I could just pile on that, you heard it's, you've got an insurance card to people who know how to use it, right?
Yeah.
And getting the answer to the question around what's covered and what's the copay is sometimes hard today. Now, if you add on to that, what's covered, what's the copay, with which provider, in which setting, for what circumstance, and what previous condition, right? Getting that information in someone's hand as they're making the decision, in both the provider's hands, the patient's hand, is a challenge across sort of the entire system, and enabling that is going to be necessary for people to be able to make those decisions with the way sort of the insurance market is going in terms of getting to that more individualized point of sale sort of thing. But that is a long road to hope, because there's a lot of interdependencies to be able to answer that question. And they're not all sort of inside one spot.
Or at all.
All right, with that, please thank our panelists for a great session.